عرفش يخش هيتلغي دول وهنكمل عادي بقى. فابدأ بنهاد دلوقتي.
دكتور نهاد اتفضل.
First of all, I would like to thank Dr. Nasser, the organizing committee, and Dr. Ahmed Taha for giving me the opportunity to present here today in this magnificent work.
Okay. Dr. Nehad debates drug-coated balloon angioplasty has justifiable evidence-based indications in tibial versus occlusions. Dr. Nehad agree?
Yes.
Okay.
First of all, I would like to thank Dr. Nasser, the organizing committee, and Professor Ahmed Taha for giving me the opportunity to present in this magnificent conference. Drug-coated balloons angioplasty has justifiable evidence-based indications in tibial vessel occlusions. Quick background: critical ischemia leads to significant morbidity and mortality, and to consumption of considerable health and social care resources in both developed and developing countries. Infrapopliteal arterial occlusive disease, with or without concomitant inflow disease, is a leading source of critical ischemia. In the absence of suitable vein and or adequate Distaranov vessels, and in high-risk surgical patients, endovascular treatment represents the only valid therapeutic option for critical ischemia. But there is a problem of the durability of the endovascular procedures. So there is intense ongoing cardiovascular research toward the development of novel technologies that may limit the phenomena of vascular restenosis, aiming to increase the durability of these procedures. Before we start, we have to ask ourselves a very important question. What's our goal in treating a patient with critical ischemia? The answer is the complete wound healing or the limb salvage. This is the most important. Yet, we have other issues: the safety, the patency, the cost effectiveness. All of these should be kept in consideration when we choose the modality of treatment. What evidence do we have? These are the most important studies that had been conducted regarding the drug-coated balloon in tibial disease. One of the early studies was the Schmidt et al. In 2011 that showed that drug-coated balloon is a durable option for the treatment of the infrapopliteal disease. That was followed by the Lesatro et al. In 2013 that confirmed that results. Then the Zeller et al. Did the Impact Deep trial with an alarming signs regarding the safety of the drug-eluting balloons in the infrapopliteal region. And Medtronic had to withdraw all the drug-coated balloons from the market. So he conducted another trial, the PAVSS trial in 2015, to make sure that there is no safety issues. And actually, the problem was in the manufacture, in the coating of the balloon, which was made manually, and he proved that there is nothing in the safety of these balloons. That was followed by other trials. This is the PAVSS trial that was conducted in 2015, and the conclusion was drug-eluting balloon has been proven to be safe and effective in infrapopliteal lesions with comparable outcomes. A more recent study 1 year ago was published, was the 5-year outcome of the debate below the knee randomized clinical trial. They concluded that the overall survival at 5 years was similar in drug-coated balloon treated patient compared to PUPA. So, the drug-coated balloon is safe and durable, but is that enough? We are talking about how to achieve our goal, the limb salvage, and both modalities has nearly the same results in the limb salvage. So, why to pay an extra cost? Well, where we stand today, this paper, although it was a little bit old, the paper in 2016, demonstrate where do we stand today. It stated that the statement that drug-eluting technology gives better clinical outcome compared to standard PTA, and that is the proven technology, is not supported by the current literature. However, the statement that drug-eluting technology does not work is also incorrect. Moreover, there is enough evidence that shows the inhibiting effects on the repair of the vessel wall cells after PTA. So, the drug will act by increasing the durability still we have to justify the cost. So let's discuss the cost. If you agree that this equation is correct, then you will help me a lot. 1 + 1 = 2, which is less than 1.5, which is more than 1.5. 1 here represents the cost of a single angioplasty. If the patient had a single angioplasty and then before complete wound healing, he necessitated or needed another angioplasty to achieve the complete wound healing, now we have the cost of 2 angioplasties, which will be for sure more than the cost of 1 angioplasty from the beginning used drug-coated balloons. So our mission is to identify patients which we think that the patient is expected to have more than 1 angioplasty to achieve our goal, the wound healing. Let's dig into the literature. The early study, the Schmidt et al., was conducted, but he didn't search for investigating the ordinary lesions. He investigated the long infrapopliteal lesions, more than 10 centimeters. He did this PTA for this population of patients and found that angiographic restenosis, which it doesn't matter, around 70%, but what really matters is the need of re-intervention. He found that about 50% of the patients did the angioplasty alone, needed a re-intervention to achieve wound healing. Later, he treated the similar cohort of patients with drug-coated balloon. Again, the angiographic restenosis only in 27%, doesn't matter, but he found a significant reduction in need of target lesion revascularization, the clinically driven cause, to 17, from 50% to 17%. So it's cost effective. These are the tables. The Lisatro et al. Also in 213 did a single center randomized trial of drug-coated balloon versus PTA in diabetic patients, our population, as Egypt is a leading country in prevalence of diabetes all over the world. He found that nearly 18% of the patients treated by drug-coated balloon needed re-intervention versus 43% of the population with the PTA. So in this population, the drug-coated balloon will be cost-effective. Another trial by the Lisatro in 2020, comparing both modalities, he concluded that drug-coated balloon strikingly reduced late lumen loss, vessel occlusion, and the most important, the clinically driven target lesion revascularization compared with the balloon angioplasty. So, if we have a clinical scenario, a patient with, for example, these lesions, and we succeeded to revascularize only the posterior tibial, and clinically we know that the patient will have a major tissue loss that necessitates prolonged patency, so we need patency, then if you use the drug-coated balloon, it's justified because it will be cost-effective. So please, finally, like life, when you think about drug-coated balloon, don't have judgment from one point of view, because when you look from all aspects, you may change your mind. Drug-coated balloons are safe, effective, durable, and in some situations, it's cost-effective, like in the long occlusions, diabetic population, if the patient has a history of restenosis from other limb, or if I am anticipating that the patient will need a durable to achieve complete wound healing. Thank you.